Welcome everybody. It's my pleasure to be able to chair this lunchtime webinar. This is an ASH smoke-free NHS network event. There's a huge number of people that have registered and are logging in for this event, so it's great to see so many people. These events are always very well attended, so really looking forward to the discussion and the outcomes that come from it. This is the third in a three-part series from the network that have focused on pharmacy and drug interventions. So the two previous webinars, they are available. So the first one was quitting smoking through vaping, and the second was collaboration and smoking cessation services, community pharmacy, trusts and local authority. So those two are available. My name's Matt Evison. I'm a chest physician, and I lead our tobacco dependency program in Greater Manchester. This third webinar is going to focus on what I think is probably one of the most challenging areas to really address in delivering these programs, which is ensuring patients receive nicotine replacement therapy in a timely way. And I think we're going to hear quite a bit about how quality improvement methodology can help us to help us address this. So the webinar is being recorded. We don't think the breakout rooms will be recorded. If they are, we will update, but the session is being recorded so it can be shared and circulated throughout the network. Okay, next slide, please. I'm sure all of you are very familiar with the work of ASH, but if anyone, if it's new to anybody, ASH are a public health charity, so founded over 50 years ago, that work to end the harms of tobacco through campaigning and making change happen in the NHS. If you're not part of the smoke-free NHS network, highly recommend joining that for numbers of resources, for a community of practice, for updates and hearing about events such as these that are so well attended and hopefully very helpful in embedding things into clinical practice. So please do visit the website and join that network if you're not already. Today's session is partnered with the NCSCT, so the National Centre for Smoking Cessation Training, who have helped shape today's webinar, and as many of you know, are the leaders in national training in this field. So I'm just going to quickly introduce two members, which is Sophia Papadakis and Melanie Perry. I'm sure many of you know both Sophia and Mel very well, who will be participating throughout today's webinar and I'm sure providing guidance during some of the breakout rooms. Okay, next slide, please. So we've got a bit of housekeeping. So if you can just make sure you're muted and videos off during the presentation, but later please do turn them on, show us we've got an audience, and for participations during the discussions in the breakout rooms. The chat networks, chat function is really important. So we're monitoring that very closely. So any questions, or if you've got good resources that could be shared across everyone attending here, please do post them in there. And be very supportive of people asking questions. I've mentioned that we're definitely recording this first part of the webinar. It's unlikely, I think, we'll be recording the breakout rooms, but if that changes, we'll let you know. And everything will be shared afterwards. If you're tweeting anything about today's webinar, please use the hashtag of SmokeFreeNHS and make sure you tag ASH in it as well. So any issues, there's a contact email address there, or just post something in the chat. Okay, next slide, please. So the purpose of today is focusing on a very timely initiation of nicotine replacement therapy for somebody that is dependent to tobacco when they're admitted to hospital. And as I say, I think this is one of the most important and probably one of the most challenging areas to get right in a tobacco dependency pathway. And I think for me, it's something that really sets the tone of the admission. If we do things really well very early on, at the point of someone being admitting, it really pays dividend and improves the longer term outcomes. It's such a critical part of this. Next slide, please. So we're focusing in on that really very first interaction with someone that's dependent to tobacco, making sure that firstly we identify that someone is dependent upon tobacco, but also initiating treatment will be the core of that is around nicotine replacement therapy. Of course, we can discuss there's a role for vapes as well in that. I'm going to say a few words on that in a little bit as well. And this is all prior to that, the review and referral and a specialist team getting involved. This is front door, immediate identification of tobacco dependency and immediate initiation of treatment that is going to prevent withdrawal and help manage cravings. And as I say, I think this is, it's hard because this, it falls on the shoulders of admitting clinicians that rotate very often through hospitals. There are training needs, but it really does set the tone for the rest of the pathway. So I think it's brilliant that Ash have put on this and the network have put on this webinar to discuss it, so we can hear about how people are tackling this issue, and hopefully we can all learn lots from each other. Next slide, please. So objectives of today, we're going to have a look at quality improvement methodology. We'll hear lots of examples of that. And hopefully from this, we'll be able to identify an action list that we can take away from this and look at our own practices and services about how we can develop this early initiation of NRT. And hopefully feel empowered to make further improvements within our service. We're always continually looking to improve. So I hope it's a very, very useful webinar. I'm certainly looking forward to it. Next slide, please. So we've got a talk on nicotine withdrawal and the management. I'm going to do a few polls and an introductory stuff. We'll go into a talk and then we're going to go into breakout rooms, one of which is focused on acute and mental health setting, one of which is focused on maternity setting. So please do choose which breakout group you want to attend, and then we'll all come back together and try and turn that learning into action. Just for noting, we won't specifically be covering integrating vapes into the acute service. There has been a previous webinar on that could be looked back at. The recording is on the website, so please do go in and check for that. I'm sure we'll post the link to it as well. That's just come up in the chat. Okay, next slide, please. Just a quick update on medication. Where this will be very heavily focused on nicotine replacement therapy, but as always, there are always lots of questions about medication. So a quick update. Varenicline and cytosine are not currently available in the UK. It's possible that varenicline may become available again next year. We think June is likely to be the earliest possible time. There is interest in bringing cytosine into the UK, but there are distributor issues that are being worked through currently. And whenever there's any information available, that will be updated through the Smoke-Free NHS network. So another reason to be part of that network, to receive regular updates on medications. Bupropion is going to be made available again from December after having been withdrawn. I think probably everyone acknowledges that the use of this has been fairly low in the UK, and we know, particularly in NICE guidance, there are certain interventions deemed highly effective, like combination NRT, varenicline, vaping, and others that are likely to be less effective, such as single agent NRT and bupropion. You know, the return of that medication may not have huge impacts on our practice, but I think for specialists with an in-depth knowledge of this field, it is good to have as many options as possible. But NRT, vaping will remain core methods of supporting people to stop smoking. Next slide, please. So I think we're going to go on to some polls. So just give that a second while that loads up.
I've posted the code and the link in the chat so people can join that using their phones as well.
Okay, so there's a link in the chat. You can scan that QR code that is on screen, or go to menti.com and enter that code that is on the screen. Okay, should we have a look at our first poll? So the first one is, where are you in the healthcare system? Okay, so getting a lot of answers through now. So as expected, a lot in the NHS hospital trusts, given the focus on this as a front door, frontline initiation of treatment to mitigate withdrawal at the point of admission. But good to see we have a really good spread across the ICS system, local authority system, community services. Okay, fantastic. Right, shall we move to poll number 2? So which specialty are you working in? So we've got the 3 key areas of the NHS long-term plan: acute, mental health and maternity. Okay, and a really nice spread across all of those specialties. Okay, let's move to poll number 3. Okay, so how is NRT made available in your setting? You've got prescribers, a PGD, a protocol, as an over-the-counter medication protocol, or other. I'll just wait for those responses to hit up near the top of 150 plus. Okay, so vast majority via prescribers, with then an equal split between the 2 different types of protocols, PGD and protocol driven. Okay. Right. Let's head back to the slide deck. And now we're going to move on to our first speaker. So I'm delighted to introduce Joanna Feeney, a clinical delivery manager in tobacco in North East and Yorkshire. So we're going to have an overview of the management of acute nicotine withdrawal. So Joanna, many thanks for speaking today.
Brilliant. Thanks, Matt. And really, thank you for having me here as well. I'm just going to hopefully provide a bit of a brief overview of the management of acute nicotine withdrawal, particularly within an inpatient setting. So if I can go on to the next slide, please. So really, as a bit of a context, smoking should be considered as a long-term chronic relapsing condition, one that normally starts in childhood, and it's actually driven by nicotine addiction. We often hear that people smoke for the nicotine, but they're killed by the tar and the other 5,000 plus chemicals that are in cigarettes. Smoking rates in England have been reducing year on year, but in 2022, there were still 5.3 million people who were smoking in England. Now, remember, this is something that kills 2 in every 3 long-term users, and for every 1 death, there is 30 people who are diagnosed and living with a smoking-related condition. So we know that smokers are therefore going to be more likely to be living with a long-term illness, many of which are going to be exacerbated by their smoking. Therefore, they're also more likely to be admitted into hospital, 3 times more likely than non-smokers. And in 2019, there were over 500,000 hospital admissions that were attributable to smoking. We also had the ambition that for all hospitals to go smoke-free, have smoke-free sites, smoke-free grounds. This was back in 2017, and it was actually embedded into the NHS standard contract in 2019-2020. which means that unless we are systematically identifying smokers and providing treatment, around about 500,000 people in hospital every single year are going to be suffering from acute nicotine withdrawal, or they're potentially going to be putting themselves at risk by maybe going off site to self-medicate and relieve withdrawal through smoking. Unfortunately, the last BTS audit highlighted that only a third of smokers who were admitted to hospital were actually offered any pharmacotherapy to manage their nicotine withdrawals. Next slide, please. So these are just some of the symptoms that are associated with nicotine withdrawal. They are wide-ranging, and in some cases, they are often confused with symptoms of stress and anxiety. It's important to note that the severity of these symptoms can vary from person to person. And whilst the symptoms of acute nicotine withdrawal are not necessarily life-threatening, as in the case of maybe severe alcohol withdrawal symptoms, but they can cause great discomfort for patients and can impact their hospital admissions. Next slide, please. So people are admitted to hospital because they're not very well. That's kind of obvious. But if you have somebody who's in acute nicotine withdrawal and they're maybe suffering from a variety of those withdrawal symptoms from the previous slides, headache, tremors, gastro problems, decreased heart rates, this is potentially going to impact the medical assessment. It could potentially also hide or exacerbate other symptoms that are relating to their illness or their admission. There's also evidence to suggest that nicotine withdrawal may influence the neurophysiological mechanisms that are linked to pain. So there's growing evidence that smokers use cigarettes to ease pain, and that acute withdrawal might actually make abstinent smokers more sensitive to pain and physical discomfort. Probably one of the most visible impacts that we see of nicotine withdrawal is patients going outside to smoke. And you can see how strong the pull of the addiction is when we see patients who are maybe fresh from surgery, standing outside in all weathers, rain, snow, to have that cigarette. This is not rational behaviour. It's not a choice for them. The addiction has removed the choice, and it also puts them at risk from accident or from an increase of risk of contamination or infection. Another non-rational behaviour as a result of acute nicotine withdrawal is smoking on site. Frequently, hospitals have fire alarms that are triggered by patients who are in acute withdrawal and self-medicating with cigarettes, maybe perhaps in the toilets. Less frequently, but more dangerously, there are examples of fires caused by smoking in hospitals. This picture here was from an incident in the University of Wales in 2020, where the damage was over £50,000, and it caused the hospital ward to close for 2 weeks. Luckily, in this incident, the patient did survive, but in my own experience of working in hospitals, I have seen cigarette-related fires varying in severity, from bin fires that are on site from discarded cigarettes to patients who have smoked in bed whilst on oxygen and have been severely injured. In hospital patients as well, studies have also reported several manifestations relating to the sudden nicotine abstinence, such as irritability, anxiety, agitation, confusion, or even hallucinations. And a study in the mental health inpatient setting found that a comprehensive smoke-free policy, where all patients' smoking statuses were assessed on admission and smokers were offered nicotine replacement therapy within 30 minutes of admission, led to a 47% reduction in the number of patient towards staff assaults over a 12-month period. And finally, if we don't manage acute nicotine withdrawal symptoms in hospital, it undermines not only the smoke-free policy and the tobacco dependency treatment service, but the fact that hospitals should be places that promote health and well-being. Next slide, please. So failure to treat acute nicotine withdrawal symptoms, it's against the NHS constitutional values of putting patients first, being compassionate, responding with humanity to their pain and distress, providing quality health care, including patient experience, and respecting and valuing everyone in order to improve both health and well-being and their experience of the NHS. We actually have a duty of care. It is our clinical responsibility to treat and manage acute nicotine withdrawal in the same way that we would do if somebody was alcohol dependent and they were admitted. The tobacco dependency treatment services are being established to systematically screen and offer that specialist support and medication to all patients who are admitted into hospital. And their treatment plans do include both support for people who want to quit smoking and also supported temporary abstinence. But going back to what Matt said, it's important to note that this is not just the responsibility of the tobacco dependency advisors in the hospital. There must be a process in place to support this on the ward as patients will start to be experiencing those withdrawal symptoms within just 30 minutes of their admission. And in most hospitals, the pathway to be seen by the tobacco dependency advisor will be longer than 30 minutes. So, for example, it might be the next day, at which point the patient will already be in withdrawal. Our aim should be to provide treatment on admission. The NHS recommended model for inpatients is that NRT should be provided within 2 hours of admission to help manage that withdrawal. Next slide, please. So this is how nicotine dependency works. When somebody smokes, the nicotine is delivered to their brain extremely quickly. This activates the receptors in the brain to release dopamine, which is the body's feel-good chemical. But as our dopamine levels reduce, we start to feel withdrawal symptoms. And then that triggers the craving for more cigarettes to get more nicotine and as such more dopamine. For most people, when they smoke, when they wake up, they will be in withdrawal. They will smoke that cigarette and to feel fine. But before too long, those withdrawal symptoms start and they will self-medicate to alleviate this. And this process is repeated 10, 20 or more times during the day where people are kind of going between their optimum level and withdrawal. Next. When people are admitted to hospital and they're in an enforced abstinence, they'll likely then to continue to be in withdrawal. Next. So in order to prevent this, we need to clinically manage the withdrawal by providing nicotine replacement therapy to keep them in that optimum zone. Next slide, please. There are various methods that NRT can be provided in hospital settings. It can be provided through prescribers. However, if there are no prescribers on the ward when the patients are admitted, this can cause delays in getting products to patients. PGDs, we saw that many people are using those. These do enable the supply of medication in the absence of a prescription, but PGDs are limited to registered healthcare professionals. So healthcare assistants on the ward and tobacco dependency advisors cannot normally utilise these. Also, the specialist pharmacy service doesn't recommend PGDs for medications that are general sales licensed, such as NRT. And then the other option, which was mentioned earlier, is the local medications protocol. So sometimes these can be referred to as a simple medications protocol. Sometimes they can be referred to as a homely remedies. And these can be either standalone or they can be incorporated within a much broader medicines policy. But the protocol would set out all of the processes, including the training, competency assessment, record keeping, storage, and any staff who is trained can utilise these, including admitting those staff on the clinical staff who are maybe non-registered healthcare on the wards and tobacco dependency advisors. And this obviously can then help remove barriers to timely access. And within mental health settings, protocols have also been used to provide vapes. So ultimately, either of or all three of these processes can work, but NRT provision should be provided in a timely manner to prevent and manage withdrawal. And we do have multiple examples of protocols on NHS Futures platforms, and I would recommend that if people have any that they would like to share, that they do that on the Futures platform. Next slide, please. So we've heard that accessing nicotine replacement in a speedy, timely manner is essential, and these are just some of the enablers. Next. Training for medics and frontline staff so that they're confident in what to prescribe and to administer it. Next, having stocks up on ward, even if it's limited to a couple of products like the patch and the inhalator, as opposed to having to order from pharmacy and then wait for them to come up. Next, clear and simple processes for protocols to make it easier for staff to follow. Decision aids, again, making it easier for frontline staff when patients are admitted. And incident and reporting and monitoring, having processes in place to monitor NRT provision, Do some wards have better provision rates than others? Is there learning that can be shared? Are TTOs being provided on discharge? If it's not being provided, is it being reported on DATIX? And then finally, the final enabler is working with pharmacy. This is fundamental. We need to ensure that our pharmacy colleagues are engaged. Next slide, please. So there is unfortunately a lot of unhelpful narrative about nicotine at the moment, that nicotine affects brain development, that it's as addictive as crack or heroin, and this can lead to both healthcare professionals and smokers being wary of nicotine products. These statistics are actually quite worrying, that 40% of smokers believe that the harm from smoking comes from nicotine, and that 11% think that nicotine replacement therapy is equally or more harmful than cigarettes. Now, this has doubled since 2019. And we've also seen that the perceptions of harm around vaping has increased too. The result is that people are often opting not to use nicotine products, or they're not being given enough to manage their withdrawal symptoms. And the consequences then is that they just go on and continue to smoke. I mean, I hear it near enough every day that people are often concerned about swapping one addiction for another. But I think it's important to remember that whilst nicotine is a mild stimulant and has addictive properties, cigarettes are highly engineered to give people the highest dose of nicotine in the quickest time. It takes just 7 seconds for that nicotine to hit the brain from a puff on a cigarette. That's faster than intravenous, and that is what makes the cigarette so addictive. Nicotine replacement therapy, by contrast, it has lower dosages, it's slower releasing, it's therapeutic. No one becomes addicted to the patches, and very few continue to use the gum or the inhalators long term. Even where they do, there is no evidence of long-term harm from nicotine. NICE states that NRT has been demonstrated in trials to be safe for use for at least 5 years, and even lifetime use is likely to be considerably less harmful than smoking. Next. So remember, both NRT and vapes are recommended as treatment options by NICE. And next slide. So just in summary, and before we go to the breakout rooms, the acute management of nicotine withdrawal is a clinical responsibility. Whether somebody wants to make a quit attempt or not, we have effective evidence-based treatments that will both alleviate withdrawal symptoms and support a smoke-free site. And pathways should be in place to make it easy, quick to access. And if people are still suffering from withdrawal, we're likely underdosing them. And we need to ensure that we're providing enough of a dose to keep them at the optimum level and to keep them smoke-free. Thank you.
Fantastic. Thanks, Joanna. That was a brilliant introduction to this topic. I think you've very, very eloquently described the medicalisation of tobacco dependency. And whilst that's only one component of treatment, it's such an important one for this particular topic, ensuring the initiation of treatment on admission, because that will fall on clinical teams' shoulders rather than a tobacco dependency service. So I couldn't agree more with everything you've said in that. I think one of the things I really try and push on ward rounds and when on call and when teaching junior doctors is about putting tobacco dependency as a comorbidity or as a reason for admission in the acute diagnosis list. Because as soon as it's in there, that simple little where it's written and where it goes and how it's thought of, then immediately puts it into a management strategy. So if someone's being diagnosed as having pneumonia and tobacco dependency, their management plan is going to include antibiotics and nicotine replacement therapy. It puts all of those things together, a disease and management process. So thank you very much for that, for the introduction. I think it's set the scene perfectly. So we're going to move into parallel sessions, and there's going to be some presentations, but also lots of time for discussion. So there should be about half an hour for discussions. There are two sessions to choose from. So for acute and mental health, we have 3 speakers. So Mike Smith, Healthy Hospital Programme Manager from Rotherham NHS Foundation Trust, is going to talk about the acute setting, what their experiences have been and how they've used quality improvement. Agechi Anakoro Trust and Forensic Lead for Tobacco Dependency for City and Hackney for Mental Health, is going to specifically talk about the mental health setting, and Clementine Bunce, Quality Improvement Coach from the National Collaborating Centre for Mental Health, will also discuss the work on NRT. So for those particularly interested in the acute setting and mental health setting, please do choose that breakout room. And in the other one, we have Heidi Croucher, the lead tobacco dependency midwife for NHS England Prevention and a tobacco dependency program manager. And she's going with Jeanette Beer, smoking and pregnancy support worker from the University Hospitals Dorset NHS Foundation Trust. Okay, so in terms of a working agreement for the discussions, we're all the engaged and the people that really believe in this, and this is it's a massive opportunity for us to learn from each other and be supportive to be for each other. We know there are some difficult topics in this field, a great deal of misinformation around, a great deal of stigma, deeply entrenched views that we have to overcome. And so hopefully this is an environment where we can discuss evidence-based information, a forum for open discussion about those topics. So I guess it goes without saying to show appropriate behaviours when we're discussing some of these more challenging areas, and create a healthy environment for that discussion. Okay. Information on vaping. So I did touch on this earlier. It will be part of the content in the maternity session, but we know it's a topic where there are strong views, where there's misinformation out there, and Ash and partners follow the Chief Medical Officer's stance on vaping, and we've just put up Chris Whitty's stance as a CMO. If you smoke, vaping is much safer. If you don't smoke, don't vape. Marketing vapes to children is utterly unacceptable, which I think just summarizes it perfectly. The swap to stop scheme is an important part of implementing vapes into the tobacco dependency treatment field, and there's links here to resources that really do tackle the myths around vaping and the misinformation around vaping. So please do go and check those out if you need any other sources of information. Next slide, please. So this is how to reach the breakout rooms. So I think we're just showing on slide. There is an icon to select the breakout rooms at the bottom of your screen. Breakout room 1 will be the acute and mental health setting, and breakout room 2 will be the maternity. So hover over that breakout room and it will come up with the 2 rooms, and assign yourself to the ones you want to join. So if everyone wants to do that, we're going to reconvene again at about 1:45, where we'll turn learning into actions. Thank you. Okay, so I think most people are back into the main room. So I hope that they were helpful breakout rooms, and that it was useful to go through real world examples of quality improvement. So in that acute and mental health setting, there are some fantastic examples of quality improvement work, and lots of things I've jotted down to reflect on. What we're going to do is just have another set of polls. So the first set is just going to help us reflect and identify what top tips and what actions people will be taking following this event. And that will be helpful for us to bring all together, and then that can be shared across the network. The second set is a bit more quick fire, and they're really feedback for the team putting the webinar together and the ASH team to understand what other learning requirements there are and what might be needed for the future. Okay, so if we, same rules again, QR code, link in the chat, or go to menti.com and enter that code. So if we start with the first poll. So top tips that you'll take away from today. And I'll leave a bit of time just to, so these can start coming in.
Sorry, Matt, I missed the code.
We'll push.
So did I. Sorry.
It's on the top of the slide where it says join me at Mentimeter. There's the codes on the slide in front of you.
Great, thanks.
Yeah.
Oh, the link's on now. Oh, finally, it wasn't on when you said it was in there.
Okay, so I think a lot of what's coming in are the processes within this. And that's, so the actual, how you, the technical aspects of how you get that NRT to a patient, be that the person that does it and the mechanisms by which, under which they can function. And I think that reflects, that has really dominated the discussions, and particularly in the breakout room I was in, was very much about those interventions. So that's really helpful. Okay, loads coming in. Okay, shall we move on to the next poll? So that is, what action will you be taking following today's event, or what would you be doing differently? Okay, so lots about training, and lots about protocols. So just worth highlighting again the Smoke-Free NHS network and the resources that are available in terms of examples of protocols. And I think probably just also worth highlighting the work that's going on with the NCSCT about national training for both tobacco dependency advisors, but the delivery of the tobacco dependency pathway. There is going to be national training resources it's really good to see that this is coming out as a big theme, because it very much verifies that this is some important work. I don't know if Mel or Sophia just want to mention anything on that while it's clear it's on people's minds.
Hi, Matt. Sophia's
Thanks,
had to
Mel.
leave. But I'm
sorry
here
to put you on the spot.
I know, I'm like, yes, we are developing a suite of training resources that with NCSCT have been commissioned by NHS England to provide, along with to provide a new version of the standard treatment programme that is currently provided by NCSCT for community providers, but we're writing a new version for inpatient, specifically around treating tobacco dependency and the pathway and the protocols involved, with a clinical checklist, key points and messages, and all trying to align it also with the BTS clinical statement that is out shortly, maybe by the end of the year too. So yeah, those we're piloting in the next couple of months, and then hopefully rolling it out after the new year for people to access. It'll all be there housed on the NCSCT website.
Thanks, Mel. And so, yeah, we've mentioned two really important developments that are coming. The British Thoracic Society are publishing a clinical statement with very much aimed at frontline clinicians rather than tobacco dependency advisors. The NCSCT are producing a suite of training resources for tobacco dependency advisors, but there is huge overlap between the two, and there is a lot of consistency between the two that is coming. So do keep an eye out for those.
May I just say,
Right.
in tune with something else as well? I know that Melanie, you put together a really nice summary of what's available out there currently, just to fill the gap, didn't you? And posted that on Future NHS as well. So And that's also out there for people in the interim until the wonderful training comes available. It's just
Yes, it's on Respiratory Futures.
Okay.
Futures. Yeah, it's on Respiratory Futures.
Oh, okay.
I'll put the link in the chat.
Great, do. Thanks very much.
Okay. All right. So should we move on to the next polls? So we won't see live feedback on this, for anyone's worried. This is to be just be used for review later to understand if we're meeting the educational needs of everyone that's attended and what the future will be needed. So it's still going up, the numbers feeding back. So I'll just give that just a little longer. Okay, should we move on to the next poll? Okay, anything that we need to tweak? Okay, so lots of positive feedback in there, but equally lots about the importance of discussion. And it was time never feels enough. In the breakout room we had, I think we could have spent hours unpicking a lot of what was discussed in there. So that will very much be noted for future design. Okay, I think the next one is probably then the last one, which is about what should we keep doing. Don't worry, all of this feedback will be looked at and summarized. So what should we keep doing? Okay, so again, lots of supportive comments there. Thank you very much for everyone who's responding to that. It's you know, we've had over 300 attendees at the webinar today, so that is huge, and it does really make it feel like a network of people and a community of practice trying to deliver this critical program of work. Okay, so I think what we'll do, we'll just wrap up and draw the session to a close. So on behalf of myself and the speakers and everyone at ASH and the NCSCT, we do wish you well with the implementation work of the tobacco dependency programs. We all know the importance of these programs and how far things have come in the last few years. In one of those introductory slides that Joanna shared was the BTS audit results, which the BTS now have run 3 audits on tobacco dependency, all of which there was very, very little change in the outcomes for hospital patients. But it's so clear that that's been we described it as the dark before the dawn. There's been an unprecedented investment now in these programs, and you can see from the presentations today the change that is happening, which is quite incredible in such a short space of time. So we wish you all the best with the implementation and ongoing improvement work. Please do join the Smoke-Free Network, Smoke-Free NHS Network, for resources, for communications, for shared learning. Thank you to all the speakers who gave up their time today to prepare and deliver such important topics of discussion. And the slides and content will be shared in the future. So I will draw the meeting to a close, and thank you very much for attending.